Ma'am, we are live in 3, 2, 1. Please start, ma'am. We are live.
Hello, good evening, everyone. It's a great pleasure to welcome you all for this very exciting scientific webinar, Oncology Updates 2023. Now, it's a great pleasure to invite Dr. Manish Sharma. He is a consultant and head of unit Medical Oncology, Rajiv Gandhi Cancer Institute, Delhi 2. Welcome and introduction. Now it's over to you, sir.
Good evening, all. Thank you for joining us here at this Oncology Update 2023. And we have some of the eminent speakers from our own oncology forum. And we have eminent speaker who will be speaking on the exome sequencing. The oncology is an ever-changing branch, and of late, many of the new targeted agents and many of the new things they have become available. So the space has become so crowded by different competitors that we don't know which sequencing to use, from where to use, how to use. So we have plenty of ifs and buts, especially about exome sequencing. So we are doing hotspot mutation testing. We have doing comprehensive gene panels. So we will be discussing on exome sequencing. And for discussing exome sequencing, we have Dr. Prashant, and he is head practice oncology from Strand Life Sciences, Bangalore. So he'll be discussing on exome sequencing. What is the oncological perspective? I welcome you, Dr. Prashant. Please take ahead.
Thank you, Doctor. Sir, is my screen visible?
Yes, your slides are visible, and you are audible also, sir.
Yeah. Thank you, sir. So, good evening, Dr. Sharma, and good evening to everyone. It's indeed a great pleasure to be with such eminent speakers and also the participants. It gives me so much pleasure having worked elsewhere in the different countries and coming back to India and be part of this. So thank you, sir, for giving an opportunity. As I saw the instructions, so I'll make sure that I will cover within 25 or 20 to 25 minutes so that we will have one or two questions also. My presentation content is the slides moving? Just this, because I cannot see the slides.
Right.
Now presentation content, second slide, sir. Yeah.
Presentation content, yes, we can see that.
Okay, thank you. So these are the overall, how the sir told, it sometimes becomes very important to understand the test report or the results and interpretation. So I just balanced it by between the fundamentals of the exome sequencing and also the other aspects of the exome sequencing. So in terms of, before doing this, let's have the small 1 minute spent on this fundamentals of it. So in the fundamentals, basically, because all of you are oncologists, you know that there is a hereditary and the sporadic different tissue samples. So in the today, what we are more focusing on whole exome sequencing is the hereditary one, so which is basically the inherited and germline tissue. So in the sporadic one, probably in the subsequent sessions, if I get an opportunity on the different somatic panels and different somatic mutations, we can have the discussions. But cancer, both a genetic disease and a hereditary disease, because sometimes there is always a confusion between genetic diseases are all hereditary and all. But as all of you are aware also that somatic mutations, also there are changes in the genetic pattern of it, so the genes get changed. So in that perspective, more of these are like 70 to 80% of this is a sporadic, and 5 to 10% is inherited. Like most of them are familial and the hereditary inheritance pattern. But before that, we need to know also the age of occurrence, the progression of the disease, because and the inheritance pattern, whether it is an autosomal inheritance, and also in the autosomal inheritance we have the autosomal dominant, autosomal recessive. So, and germline is usually from the reproductive cells, blood and saliva. So we can have those analysis, and somatic is from all the other tissue samples. But please remember that an individual with germline mutations may also develop cancers in somatic tissue. So it's just the statement for us to take the conversation to the next one. So now I have the third slide, the whole genome, whole exome, and clinical exome. So here what is whole genome? So the genome is the sum total of all the genes present in an individual or an individual cell. So because the cells are usually made up of the cells together make the tissue. So it's a sum total of all the genes, sum total of all the exonic regions, which are all the coding regions, become exome. And clinical exome is sum total of all. I have a small table, then I will probably speak about that. So within the cell, we will have the nucleus. So nucleus has the chromosomes. So human beings have the 22 pairs of autosomes and 1 pair of sex chromosomes, and they all contain the DNA. And these DNA are the building blocks for the genes. So what happens is these genes contain 2 phases, like introns are the intervening sequences and the exons are the expressed sequences. So what does expressed sequences means they are the ones who produce the proteins in the body. So from everything, like either it is from the different types like enzymes or to the different blood, and all of those come under the proteins. So in the whole exome, if you say whole genome, if you take as apple, a piece of that is the exome. That means it's the 1% of it. So what does this whole apple contains is the 3 billion pairs of both the coding and the non-coding sequences. So that's the area how we are all made up of, and which codes for all the different characters and differences. But what happens is in that only 1% is the meaningful with regard to, or rather we have could able to explored only those things, because in the future there may be new proteins and could be identified associated with these sequences. So those are the around 1% of it, that is 30 MB of the genome, the coding sequences. So today's one is the whole, only about the whole exome, about it. And then, but this slide on the right hand side, a cartoon I put is there has always been a difficulty in way we identify. It can be SNV, like single nucleotide variant, easy to identify. Indels are okay, 10 to 20 bases is easy to identify. But copy number variants is little average, like a difficulty. But structural variants and larger indels are very difficult. So in whatever the whole exome we are going to discuss now. So just as one short differences between the clinical exome and the whole exome. So clinical exome covers around 6,000 to 8,000 genes. So these are clinically important, or rather have been very well validated that they are very clinically important. So, and it can be because of the non-communicable diseases, most of them, or cancer or cardiovascular diseases, or a neurological or a differences or the associated diseases and all. So there the diagnostic yield is only 20%, because 1% of the exonic region is already so small. But in this, we are targeting only around 6,000 to 8,000 genes. So it is only less fruitful in terms of clinical utility. That's the one of the reason that whole exome has come into the picture, where we target almost 19,500 genes, but there are some library kits. So you can say 20,000 is the max we can cover the genes, and diagnostic yield is around 30 to 45%, because you also know that the non-coding sequences or the other different types of variants also play a very important role in our clinical practice and all. So this is dependent on the OMIM. So this is basically the Mendelian genetics, if you all remember, like one gene, one enzyme, or one gene, one protein kind of a hypothesis. So, and if negative test result comes in the clinical exome, then reflect testing is the whole exome. But in the whole exome, if the negative test result comes, all the whole genome sequencing I have written here, but at least from the oncology perspective, I don't think the whole genome sequencing has any relevance, for us, but reanalysis with advanced bioinformatics tool over a time like 6 months or 8 months will be a good decision and all. So this is just a short our strand hereditary cancer portfolio. We have 19,500 genes and around 4,14,300 probes. Cancer related is around 350 genes, so which distributes to different types of cancer. So here I have the three important statements I would like to be to set the floor for the discussion. Like inheriting a cancer related genetic change like a variant or a mutation does not mean that a carrier will definitely get a cancer. This just indicates that mutation carriers have higher than average risk of developing cancers. And germline cancer test analyze the cancer-causing mutations inherited from parents only. Therefore, interpretation of mutations and test results are focused only on the risk of getting the cancer in the lifespan of individuals. Of course, the clinical exome covers the other disease patterns. And this is the specifications if we go by. Of course, this NGS has been optimized drastically. When I was doing in the NIH in the 2002-2003 with the Affymetrix, and also those times microarray was so more powerful. But now with the NGS technology, the massively parallel sequencing, what we all of them are using in India are very powerful. So these cover a lot of copy number variation very efficiently, single nucleotide variations, small indels and structural variations. Of course, they are 100% sensitive and specificity is 99.99. So you will come to know that how the VUS need to be still validated by a second method validation. Of course, the gene target region cover is 98% about, because the genes or an exonic region present in the centromere of the chromosome are very difficult to be separated and sequenced, and genetic variations. So we have one of the best software in the India. So this is to go to the next level, our clinical utility. So next subsequent slides will be very relevant to the clinical slides or based on my experience in different hospitals. So diagnosis, yes, this is going to be very useful. Monitoring, I have not added here because there are more powerful technologies or techniques involved, because we are only speaking about the NGS today's one. Therapeutic selection, still I take it because there is no applicability, and better treatment planning. So, and patient management, of course, genetic counseling, prevalence and health risk, and research and drug discovery. So these are the very important clinical utility from the perspective for us. But what is the benefit to the patients per se? Yes, the family history, and once we take the family history, we can say early onset of cancer can be done, and multiple primary cancers in one individual, especially in terms of sometimes in the Lynch syndrome we have seen, or multiple family members affected with one or multiple categories of cancer. So then also this kit becomes very useful, and rare cancers in the individual one individual or a family members, close relatives and all. So remaining all are like predicting the risk of developing cancer or confirmation of the initial diagnosis of cancer, because still you will see in the subsequent slide how hereditary breast, ovarian, or the colorectal cancer displays a very important role, or risk estimation in the unaffected family members, and of course early surveillance. And in the prenatal cases, although I'm not taking the reproductive health in depth now, but certainly in the prenatal, this has a great value, and of course preventive surgical decisions and the patient counseling. So when do the doctors choose this WES or a broad hereditary germline panel in clinical practices to achieve some of these, like either they, like I told, different scenarios like patient categories. So our newborn screening or diagnostic testing, carrier screening, prenatal, pre-implantation, predictive and pre-symptomatic, of course forensic testing. So these are the patient categories which I just classified based on so many tests we have done. The patients with aggressive solid tumors, because whenever I have a discussion here in India, I will come to know that there has not been any data available in the hereditary risk in the particular family. But once the affected comes to the doctors, they will already start with depending if already at an advanced stage, like stage 3 where resectable tumor is there. So we start with the somatic one. But patients with aggressive solid tumors, recurrent or relapsed tumors, confirmed by medical imaging test, patients' first-degree relatives, all these are eligible, like second-degree relatives are eligible for hereditary cancer panel or a mutation-specific test. Patients with known family history of solid tumors and and unaffected first degree or second degree relatives are eligible. And then patients with unknown family history, where patient presents with an undifferentiated cancer type, and patient and his first degree relatives are eligible to get tested using hereditary cancer panel, because here already they have an undifferentiated cancer type. So we go for the somatic test, but patients and his first degree relatives will become eligible for this. And of course, the patients looking to enroll for clinical trials or clinical research studies. So some of these are very important. And when I was looking at the guidelines, because sometimes it becomes very important for me to map what we are offering to what are the international guidelines. So these are guidelines are available for, all of you already know, but these are very important. And it clearly says, I have one slide summarized from this. So, for example, some individuals may carry pathogenic or likely pathogenic germline variants in more than one cancer susceptibility gene, because in those perspective, like I told, more than 250 to 300 genes, a comprehensive hereditary cancer panel, when we do that, that's where the NCCN guideline says that multi-gene panel becomes very important for individuals already known to carry a single pathogenic or likely pathogenic germline variant. From phenotype-directed testing may be considered on a case-to-case basis based on the degree of suspicion for there or additional variants. So germline conformity testing should be done when a pathogenic variant is found on a tumor genomic testing. So this I have been sharing in different hospitals, both the private hospitals, and also I try to tell them having that gives a kind of additional information to the family to have it. So it's not like an additional burden in terms of pricing, because now test prices and the TAT have really come down. Tumor testing is designed to address treatment actionability, not the germline status. So therefore, a variant that may be considered a pathogenic or likely pathogenic in the germline may not be reported at all in some cases, because sometimes, especially in the HRD, all of you are available. People always come back to me, sir, do we need to genomic BRCA again when the HRD comes positive as a GSS score only, not a BRCA or a pathogenic? So in those perspective, I'll always go back and tell them that, so the kind of the mutations which are all somatic and the germline are very different in way of bioinformatics analysis. So that way, this statement, I took it from there, which is there in the NCCN guideline also. The filtering of raw sequencing data may differ between tumor and germline testing labs, so that variants reported out with one analysis may not be reported with other. So these are some of the carry home message for us from the NCCN guidelines. So of course, any tests in any of our medical field, we have the limitations of the hereditary cancer panel also. So here it should not be used as the screening test for the unaffected individuals. Although I do understand personalized genomics has been picking up now in India, but as a predisposition factor, because there are always two ways of doing it when we are taking a consent. So that's why I have just put one slide on genetic counselors also, because they play a very important role in such a scenarios, because the pathogenic, likely pathogenic mutations can cause the anxiety, fear, grief, and sorrow in them. So that way, promote this comprehensive germline panels for healthy individuals, but make sure that they are aware that there will always be, like I rightly mentioned, it doesn't cause, but it only the average, more above average probability if they identify any pathogenic or likely pathogenic, and also intended to detect germline alterations only, so should not be used for somatic variants. So, and the panel does not cover the mitochondrial genome. So we are also planning to come out with the mitochondrial genome and the other kind of RNA sequencing ones and all, but yeah, we are at the validation stages. And this VUS has been a topic at least every week or alternate week. I'll be talking to many of them whenever the reports are released. So this, I thought to spend 1 or 2 minutes, mutations with insufficient information to delineate the risk. So please remember that Strand has one, in the whole of the, historically, we are the one probably report less of VUS compared to other labs. So simple reason is the mutations with insufficient information, because whatever the databases we are using or of international data will be there. So, and as usual, you know, in India, we are so many labs are doing, but there has not been data migration or collation of the data. So So we all work in isolation. Here, in at least strand proprietary data, we validate it with an Indian subcontinent in terms of prevalence and frequency score, so that we can classify the VUS either as pathogenic, likely pathogenic, or with the conformity we can tell VUS, but however, based on our experience, no any kind of surgical intervention or not required or something, we can always be able to say that. And mutation specific testing of affected family members, whenever the VUS is detected, it's I recommend it's like case to case basis as per the recommendation of treating oncologists, because sometimes it becomes, because you are all sitting in front of the patient, so you know what anxious or and all. And I've been whenever I was in APSICON or the masterclass in lung in Mumbai, or recently in Prashanti Cancer Care, so there always been this kind of debate happening that a patient comes back with saying, I had children. So some of those things I handle it with the counselors and all. And reclassification of VUS over time is always possible. So who are all your patients? So please make sure that there's a possibility is always there, and counsel the patients based on the personal family history or clinical history and surgical intervention. So this is, I think all of you are aware, there is recent guidelines says very clearly, we based on the VUS, any kind of the surgical interventions, we really require a proper counseling. So another few slides. So I have around 7 to 8 minutes. These are the 4 types of reporting which we are very much confident at this time. So probably this brings us the unique compared to the other labs. So sample QC report, because although in the somatic tissues, this has been very important for us to calculate everything, but here sample QC report, 99% of the time blood collected and transported to our lab gets successful and get a valid test report. But patient report, there always been a test report, and whenever there is a VUS is there, we only recommend and we only do the second method validation by using the Sanger, and make sure that we release the report and share with the treating physician and to the patient. And a mutation specific test. So whenever there is a pathogenic or a likely pathogenic loci is identified, we make sure that we reach out to the patient during the post-test counseling and make them realize how important it is to get a MST for tests for the remaining family members, especially those first degree relatives. And bioinformatics, one of our strong portfolio, where reanalysis of the report. Earlier we were doing by default, but now with this huge number of samples coming, and also we make sure that reclassification of VUS and all, we do it on regular basis in our lab. But whenever the patient comes back or a doctor gives the review of a reanalysis one, nowadays we are doing the reanalysis at a nominal charges. So that time we do the interpretation of the newly classified variants, and also we use the revised guidelines to do any kind of those classification of the VUS identified earlier. And also sometimes there has been a reversal, like pathogenic, likely pathogenic have suddenly, especially in somatic cases, it happens those. So before ordering the whole exome sequencing, what I always would like to share with all of you is the role of each of the gene, because especially this first point is very important from the perspective of somatic tissues, because doctors always come back to me that, Prashant, so many genes are coming now, so how to keep track of it and all. So in terms of that, so if you are not keeping track of it from the clinical conditions, but at least make sure that the lab will able to give what are the variants detected and how these variants will cause a damage to the tissues of that particular clinical condition. So that at least you need to make sure they are describing, because sometimes they don't describe, all the labs don't describe it the way we go back and say, describe all those loci and the genes and everything. So even if it is VUS, and benign and likely benign are not reported, and pathogenic, likely pathogenic and VUS are reported always, and zygosity in terms of heterozygous or homozygous and a inheritance pattern are always reported. So and also it is very important to have does the lab report secondary findings or incidental findings? So especially in cases I have seen this usually happen in the personalized genomics, that they have come like when we ask them to tick mark some clinical conditions, they tick mark, but some of the diseases they leave there. And so when I have a discussion with the treating physician or a pediatrician or an oncologist, so they say that no pressure, no need to report, or sometimes they, okay, let me come back to you, or how you will able to report it, with what confidence and all. So this is also very important in the cancer, because there is always, especially in the Lynch syndrome and all, or some of the multiple effect of the genes are also, we have it in our cancer. So in cancer genomics, it becomes very important to get the secondary findings or incidental findings, and then it requires the proper genetic counseling and to us. And of course, this contents, all of you are aware, so I will just skip because I have the nice slides later. So test results, in the interpretation of the test result is very important, and all these details should be there in the test report. And of course, the test limitations, like I mentioned, and the reference of the literature and the recommendations, because whenever there is we have now so much of DM in clinical genetics, or PhDs with more than 20-30 years of experience in this particular field, who can come out with recommendations where you can consider, or it will help you to make a proper treatment decisions or counseling the other family members. So, and a disclaimer note, but however, I do see that in India, because the way in the CDX companion diagnostics in elsewhere in US and UK, they are doing now harmonization of the program, like either a CDX1 and all. Like these are the things base minimum need to be there. So I think in the whole exome sequencing, still it is lacking in India. So we have to do clinician friendly test reporting format. And of course, the interpretation and the summary findings in the genomic report should contain likely pathogenic, and VUS, and the zygosity details, and the follow-up details. So whenever I was having the different CME elsewhere, so I was having some questions, these 3-4 questions. So what types of results will be reported from the patient's WS? So whenever I ask why you're asking this, they always say secondary findings is not mandatory. That's why they will not report, as some labs will say. But at Strand, we do both primary findings, which are all focused based on the whatever the prescription is there, and also the secondary findings expanded, we always give by default. So secondary findings sometimes maybe other genes which are all related to the same condition, but it will like affected, it's not there already at the affected stage. So in those conditions, it becomes very important, and which variants found by the WES will be confirmed by the second method validation. So this is again very important in terms of this, because there has been sometimes heterozygous VUS are there. So if we have not identified by Sanger sequencing the whatever the zygosity of that, then it might mislead, because especially in the prenatal cases or the couple carrier screening. So those cases, we make sure that all VUS with pathogenic, first pathogenic, likely pathogenic, we do second method validation, and variants of uncertain significance related to the proband's medical condition. And of course, the medically actionable genes, we do second method validation, and carrier status we do, and also the any other tests which the laboratory found, we have a discussion at the post test level with the doctors and make sure that whether it is required a second method validation. So if reanalysis is required, as I told, we are doing it at nominal charges. So this genetic counseling pre-test, post-test is very important, especially in the whole exome whenever the cancer for hereditary we do, because it gives the overview of the sporadic and familial and hereditary, because some people will not recall, or we will not know why they have the hereditary risk, means why they have not been earlier faced any kind of clinical symptoms and all. So in those cases, those doubts, as oncologist and all, we will not have time to address all those in the clinics, but it's a very good habit to send them to the pre-test counseling or a post-test counseling. So our counselors follow, cover all these details and risks of cancer also, so that it becomes an awareness. So because this time 4th February I was seeing when the word cancer, so close the care gap, so it becomes easier for the reducing the burden. Of course, recommendations of carriers and test these details. So these are our GC team at Strand. So we have board certified counselors, 3 of them, Dr. Zubeda, Lisha, and Krishangi, and also the 2 of them, we are training them. They are all masters in medical genetics, so Aishwarya and Sabya. So now that's why these are some of the complex ones. We will not have time to do it, but certainly our genetic counselors are well trained to analyze this and identify those who are all in this cascade of testing are eligible to get an MST and all, and understand the patterns and other related genetics. So thank you very much for your attention. So yeah, if any questions, I'm willing to take, Doctor. Yeah.
Thank you, Dr. Prashant. I think that was a wonderful talk and delivered. If there is any question, we can take those questions.
So, hi, Dr. Prashant. So,
So-
it was a wonderful lecture.
Thank you.
So, I have one question in my mind. So, Dr. Manish, you were asking question. I think first you go ahead, and then I will
No,
ask.
you please go ahead. Please
Okay,
go
fine.
ahead.
So, Dr. Prashant, nowadays we have seen a surge in the usage of CGP in our clinical practices.
Yes.
So, so there is always a question in my mind. So, that if you are only targeting one mutation, like if you want to look at EGFR mutation, so if you are doing a single marker test versus you are doing a hotspot mutation test in 52 genes or 53 genes, vis-a-vis a CGP profiling where you are performing maybe 500 genes and you are doing complete analysis of those genes. So
Yes.
the sensitivity of which test will be the highest? So first of all,
Yeah.
and are there any chances that the thing which we are observing in a PCR based test where we are only focusing on one mutation vis-a-vis a 500 gene panel where we are distributing the same amount of DNA in 500 genes, so will there be a difference in identification of the aberrations?
Yeah. Yes, doctor. So first, I will answer it short. Like there is no changes in terms of the sensitivity and the specificity of the assay if it is within the same technology. What I mean is NGS, 3 genes, or like you say, or EGFR 18, 19, 20, 21 with whatever the 46 mutations or 30 mutations, or BRCA1 and 2, we have 46 mutations. Within the same test method, there will not be any changes in the sensitivity and specificity. If I go back to say comparison with MLPA, BRCA1 and 2 or and all, certainly there will be a changes or differences in the sensitivity and the specificity, doctor. And if it is why it is like this means although we use say like 40 nanograms or the 60 nanogram as an input DNA, when initial stage is the amplification, PCR amplification. So we increase depending upon the what should be the ideal quantity of DNA required for preparing the fragmentation analysis. So in those perspective, whatever is covered in the like for example, EGFR covered in 80, 90, 20, if there are like 30 to 40 variants we are covering, if we are having a typical any of the actionable panel or a comprehensive genomic panel with 500 genes, certainly in terms of coverage of the target gene will remain same. And this can be validated very neatly in our, or can be caught or spotted during the bioinformatics analysis with regard to the coverage in the target region and also how many of reads are there. That is where some of the slides I deleted with the, probably I will come back, like say sequencing depth or what is the read depth, whether read depth will remain average, read depth remains same for all the 500 genes what we are covering, or in the 3-gene panel or a 4-gene panel. So it's depends from lab to lab, doctor. More than 500 reads I'm going to accept it, means all those are less. In our lab report, if you see, we always write the following are not considered for analysis because they were less than 200 reads and all. So those are the guidelines which are all available, and certainly it play a very important role in the interpretation, because if it is not covered, that particular sequence is of, or a gene is of very important to you, you have to ask the lab for a resequencing.
No, but in that case, like if you are doing a 500 gene panel, so you might be getting 15 mutations or 20 mutations or more than that also.
Yeah.
So are there any chances that the mutation, like, so first thing is that is there a very good concordance between a hotspot panel versus a CGP? So
Yes, yes.
do you really feel that when you do a 53 gene panel, like if you have detected some aberration in 53 gene panel, and the same will be highlighted in the 500 gene panel also?
Yes, doctor. Yes, doctor. It has been done in the elsewhere also by different labs, and also we also do the same analysis. So in terms of the pathogenic loci identified, and certainly with the pathogenic and likely pathogenic, I will say with confidence that more than 99% concordance is there for hotspot mutations or the driver mutation.
Okay, thank you.
Yeah, thanks.
Dr. Prashant, so in your talk, I think you said that if you are doing a test on the blood and you're finding some mutation,
Yes.
it may sometimes be not present in the tumor tissue as well. Is that correct? What I understood?
Yes, doctor. Yes, doctor. So
So if I order a BRCA mutation, germline mutation,
yeah.
So that would mean surely that I have to order a tumor mutation as well to determine that my olaparib or rucaparib would work.
Yes, doctor. So I'll just give, since it's a specific example. So if we do the genomic BRCA analysis, the kind of whatever the mutations or variants present in those 46 exons, it will cover, which are heritable of which, if there is a strong clinical history and a family history, if you agree, certainly doing it will help to do the patient counseling and the counseling of relatives. And if likely pathogenic BRCA variant is identified, olaparib or PARP inhibitors are going to be certainly effective on this. But in cases of the somatic one, say somatic BRCA, I would like to do now. So what are those mutations? Means those mutations which have acquired during the lifestyle, either if the patient has any of other lifestyle kind of things, or because of the acquired mutations. It can be like microsatellite instability causing one, or loss of heterozygosity. These will happen during the like a DNA to mRNA, like messenger RNA transcription, mRNA to protein synthesis. So those
this is what you detect on HRD, no?
Yes,
this is what you detect on
yes,
HRD.
that
so
is
this
the
is exactly what you,
exactly.
So I mean to say that you have to do both the tests, that is on blood and HRD testing, to be sure that the drug is going to work.
For the proband, one of the tests is always sufficient, or rather I will say if genomic BRCA comes negative, there is always a probability that HRD, when we do it, there can be positive, because some of the alterations identified at the somatic level might not be present at the germline level. But in terms of the usage, doctor, wherein like for lung cancer, you also know where actionable is completely there. We cannot identify, although there are genes, but mutation don't happen at the germline level. So that's the first one. And second one is doing both of it. If you do both assays, germline BRCA comes positive for a proband, you can counsel the other family members, or you can rule out other Lynch syndrome or any of them in the family members. So it's that the positioning is entirely different from the perspective of advising both genomic BRCA and a somatic BRCA to the same individual. But if anybody is doing in a reflex way, if genomic BRCA is negative, then if they have to do either a MLPI BRCA or a HRD BRCA, just to make sure or rule out that there are no other acquired mutations in that patient.
So we are running short in time, but just a last question, that so many labs coming in, how do we decide that which lab to go for? So how do we decide that which is the best lab for our patient? I know that Strand is a best lab, but how do we say that? What should we look on the report to tell that, yes, this is the lab which we should be going for?
Yeah. So first one, doctor, is since you know the patient and the clinical condition. So if the whether the variants and the genes what you are looking for are covered in that patient in that particular test report, and in the sequencing depth or a read depth which is required. That means in the cases of liquid biopsy, it is 8,000, average is 8,000x. But in cases of the germline, we always say more than 100x is always ideal. In cases of somatic mutation screening, we will always say like 200x. And third one is whether the labs are doing the second method validation for the pathogenic and likely pathogenic and the VUS for homozygous ones. So these are the some of the criteria need to be followed other than the, the customer satisfaction of turnaround time, pricing and other details.
Thank you, Dr. Prashant, for being here. And I think you made our evening today. This was an excellent talk. So next, I would be inviting Dr. Rajat Bajaj. He's a senior consultant at Fortis Hospital, Noida. He will be speaking on decoding treatment options for EGFR mutated NSCLC. Dr. Rajat Bajaj, I welcome you.
Hello. Yes, am I audible?
Yes, Dr. Rajat, yes.
Okay, thank you, Dr. Manish and the organizing team for having me here. I congratulate you on organizing this academic event to discuss the various nuances of the ongoing updates in the field of oncology. The role that I've been given in the next 15 minutes or so is talking about the treatment options that we have for our metastatic NSCLC patients who come out to be EGFR mutant. And I will try to describe what all treatment options are available and then what are the preferred options as of now in 2023. Next slide, please. So we have this data from world over, which says that lung cancer certainly is there on the top if you talk about both the incidence of cases as well as the mortality related to this disease. And this is the data from Globocon 2020. Second most common in terms of incidence and most common, about 18% of all the mortalities because of lung cancer. So certainly a cancer that we should be talking about, certainly a disease that we should be involved in more to find out the newer treatment options. Next slide. Yeah, next slide, please. So there are certain parameters that we actually consider once we are talking about the decoding of treatment of an EGFR mutant metastatic NSCLC. And these parameters can range from the standard endpoints of a trial being progression-free survival to the overall survival to what is the performance status of the patient to the expected toxicities of a particular combination or a treatment regimen to what are the financial implications of a particular drug to also very importantly whether the patient has got brain metastasis or not. So we do know that since the time of Optimal and the UTAC study that we have our first generation TKIs of erlotinib and first generation TKI of geftinib from the IPAS study by Dr. Tony Mock, where we understand that if we compare an EGFR TKI versus chemotherapy in such patients who are EGFR mutated, we get a better PFS compared to chemotherapy with the TKI usage somewhere around 10 to 11 months for a first generation TKI versus the chemotherapy giving us a PFS of about 6 months or so. We have known this and we've tried to improvise on this by looking at our second generation TKIs. It is there in the on the screen right now. The second generation TKIs being afatinib and decometinib. Afatinib, we have the Lux Lung 7 study where afatinib was directly compared with the first generation TKI of gefitinib and was found that afatinib was better in terms of PFS, although the OS was not very different, and the PFS also was marginally better for afatinib. Decometinib, the Archer 1050 study told us that the PFS is better by the extent of 3 months at about 14.5 months with a better tolerance of decometinib, but diarrhea is an important issue that one has to consider. But very importantly, like everybody understands and is aware that these patient population did not have any brain metastasis, and that was the exclusion criteria of this particular study. We all know that these patients who are EGFR mutant will about 20% of them have a brain metastasis at presentation, or eventually or down the line over the next 2 to 3 years will develop brain metastasis. So it's an important concern for a clinician as to what can we do to stop the progression in the brain, or rather, if at all there is a baseline brain disease, then how to really treat that brain disease as well. And for that, we have the answer, and probably the answer to all our worries, which is the third generation TKI, which is osimertinib. Osimertinib came into our fold from post 2 lines of treatment to the second line of treatment through the Aura 2 study, and then only being approved for the T790M mutation post progression of first generation TKI, to the Flora study where osimertinib was pitched in the first line with the comparator arm being first generation TKI. And there was a whopping increase in the PFS to the tune of around 19 months, with Dr. Ramalingam getting a standing ovation at ASCO also for the same, and a rewarding NEJM publication. So we still are in awe of this particular drug called osimertinib, where the PFS has been found to be the maximum, and that is very clear on the screen right now, compared to the first generation and the second generation TKIs. Next slide, please. So not only if you talk about the PFS, the numerical figure, it is very important that the separation of the curves also is early. And this, of course, are cross-trial comparisons between the first, second, and the third generation TKI. But then even if I do that mistake of doing a cross-trial comparison, one would really try to know and understand as to why this early separation of curves is seen only with Flora and not with the other studies of dacometinib and afatinib. Probably because osimertinib is a superior drug with a better efficacy compared to the second generation TKIs. Next slide. Not only that, the overall response rates are also superior in osimertinib. If we look at the response rates of the Flora study, response rates were to the tune of 80% in osimertinib. And if you look at the complete responses, they were about 7%, and there were very few progressions. So this for me is also equally important, because once I start the patient on TKIs, I promise them that they are going to have a good response rate, very low rate of progression. The first PET scan will show us a progression is something which is the possibility is very low, and it is the lowest with osimertinib. Next slide. Here it is important for us to note that if we talk about the NCCN guidelines, if you talk about the EGFR mutated space, the NCCN tells us that all the TKIs, be it erlotinib, gefitinib in first generation, or dacometinib, afatinib in the second generation, or the osimertinib in third generation, they are all category 1 recommendations. If you are using first generation also, it is not wrong at all. But then it says that the preferred out of all these is osimertinib. So if it is a TKI that I have to resort to, and if finances is not an issue, then I will resort to osimertinib. And when I say this, I have this backing of this particular Kaplan-Meier curve of overall survival for Flora also, where beautifully the curves are separating from the very beginning. If you see, even less than 1 month, the curves are separating. And this is, mind you, overall survival, which was not there in first generation TKIs, not there in second generation TKIs. Dacometinib study had its own flaws if we talk about the OS, and here the OS is in excess of 3 years. So certainly a reassuring thing for me as a clinician. If we talk about the Archer study, next slide, we have had the OS in Archer, but then it was a hierarchical statistical design which was to be followed, which is there in the editorial also, after which came after Archer publication, that there was the issue of hierarchical rank designing, and that is why probably we have to take this overall survival into. Next slide. Yeah, next slide. Not only that, there are about 28% patients who still were receiving osimertinib at 3 years, which again is quite heartwarming for us to see. Next slide. And if we also talk about, like I said in the beginning, the CNS metastasis with or without. So known or treated CNS metastasis, the hazard ratio for osimertinib compared to the treatment of the experimental arm of first generation was 0.47, whereas without CNS metastasis was 0.46. So nearly the same. It has not really differed. So if the patient is not having a baseline brain metastasis, even then the preferred regimen should be osimertinib. Next slide. And this is very important to understand that in the CNS full analysis set, the intracranial CNS, the talking about the PFS intracranial, the CNS PFS was statistically significant with osimertinib compared to the comparator arm. And if you see the median CNS PFS was not reached in osimertinib, whereas it was about 14 months in the comparator arm, with the Kaplan-Meier curves again separating widely. Also, we all are aware of the Kaplan-Meier curve from FLORA, where even if the patient did not have baseline CNS metastasis, the time to brain mets progression also was delayed to a significant extent with the use of osimertinib compared to the comparator arm. We all know that in the oncogenic driver mutation subset of patients, if there is a brain metastasis, that becomes a survival limiting factor. So if we have a drug which is beautifully crossing the blood-brain barrier, why not to really go for it? Next slide. So this is what we've discussed, that there are significant CNS responses to osimertinib which were lacking in first generation and second generation TKIs. Next slide, please. And we all have used osimertinib. I think we all agree that it is a relatively safe drug to use. Not many side effects of osimertinib we've seen. Although I have seen diarrhea with osimertinib. There was one patient where there was about grade 3 diarrhea also, and I had to stop osimertinib in between, start with an lower dose and then build it on. But then these are things which are not very common with osimertinib. Diarrhea is much more common with second generation TKIs. First generation TKIs can cause a lot of mucositis and skin rashes, which again is not seen with osimertinib. So because of the receptor sparing if a drug and can be used. Slide. Can I have the next slide, please? Yeah, so these are the EGFR TKI toxicities, which are more with first and second generation and the least with the FLORA study of osimertinib. Next slide. Not many dose reductions have been required in FLORA. There were more dose reductions required in the afatinib and the dacometinib study. Next slide. And the quality of life also has improved in the FLORA study with osimertinib compared to the comparator arm. Whereas if you talk about the Archer study, the diarrhea, the soreness of the mouth, and the global quality of life was worse with dacometinib as compared to its comparator arm of first generation TKI. Next slide. So these are the TKI options that we have, and in EGFR mutated space, we have other options of combining the TKIs with either chemotherapy or with the VEGF inhibitors. So when I speak about EGFR, when I speak about TKIs being combined with chemotherapy, we have the TMH study, we have the Canadian study, where we've seen that the progression-free survival has almost become doubled. But the problem with that study is that they have not mentioned what to do with patients who present with upfront brain metastasis. In fact, the brain metastasis data is been missing from the TMH study. The TKI plus a combination with either bevacizumab or ramucirumab, with generally both of them being combined with erlotinib also has been found to have an exaggerated PFS in excess of 19 to 20 months compared to the first generation TKI alone. But then again, the main issue that makes us really fall back always on osimertinib is the CNS response rates, or the time to delay in the CNS progression, which was not a criteria which was really raked up in the relay study as well. Also important to understand that there are about 1/3 of all EGFR mutated patients who have been treated with a first or second generation TKI, and they have only been able to receive the second generation osimertinib. So one can argue that osimertinib can be there for second line, but that not all patients are eligible to take EGF, this osimertinib in the second line. So if we have a drug which is the best drug out of the lot, why deprive so many patients of the good effects of osimertinib is also something that is a thought to ponder upon. Next slide. So like I said, that access to second line therapy is next slide, please. So we have a real world.
I think Dr. Rajat has weak signals, probably.
Hello, am I audible now?
Yes, Dr. Rajat, you're audible.
Yes. So on 30 to 40% of the patients had a T790M mutation. Next slide. The sequencing is very important, because if we sequence it properly, only then we are going to have a better overall survival. So starting with the prior generation EGFR TKIs and then treating those that develop EGFR T790M mutation with osimertinib is one option, but this is not the optimum clinical care, because one, that we don't know which patients will develop T790M mutation. Not everyone will develop. About 30% of the patients may not receive a second line treatment at all, and many a times the tissue and the liquid biopsies are not always successful. That is why first line treatment with osimertinib is the correct way to go ahead. Next slide. There are certain uncontrollable factors in sequencing, like the toxicity to the drugs, the patient's choice, sites of progression, occurrence of T790M mutation. Next slide, please. So last few minutes on the real world data of osimertinib. So next slide, we have two studies. First is the flower study. So this flower study was published in the Oncologist in 2021, presented in ASCO as well, which is a real world prospective observational study from Italy, 9 centers. And why this is a real world study is because there were about 13% patients who had a performance status of more than equal to 2. There were all the patients were first line EGFR mutated NSCLC, and the median age was 68 years. Most of the patients were adenocarcinoma, which is understood, and there were about 30% patients who had brain metastasis at the baseline. And if you look at the exon 19 deletions, about 60% of them had exon 19 deletions. Sorry, 50% had exon 90 deletions, and 73% patients had a partial response. 23% patients had a stable disease. So approximately 95% patients had a clinical benefit with the use of osimertinib. And if you look at the PFS in patients with or without brain metastasis at diagnosis, the time to treatment delay was about 18 months, and the progression-free survival, the median progression-free survival was 18.9 months. Even in patients with brain metastasis, it was about 13.5 months. So it reaffirms our belief in the fact that osimertinib is a great drug to start with in these patients with a high clinical benefit expected with the use of osimertinib. Next slide. So there was not many differences in the rate of venous thromboembolism which were reported, no differences in the survival outcome according to the age or comorbidity, and its effectiveness was confirmed even in the real world scenario, although thromboembolism which was reported was a little more compared to what it was in the clinical trial setting. Next slide. Next slide, please. Next slide, please.
Hello, Ashika, next slide. Move to next
So
slide.
this is an ossifact study which is estimated in the first line in these patients, again in the real world setting, where if you see the
I think there is some network issue with Dr. Rajat. I think the talk is over, and if there are any questions, we can take them later once he comes back in the network. My next presenter is Dr. Srejna. So I would like to invite Dr. Srejna for the next presentation. That is what a physician should know in treatment of NSCLC. Dr. Srejna is a consultant at Rajiv Gandhi Cancer Institute, Rohini. I welcome Dr. Srejna.
Good evening, Manish sir.
Good evening, Srejna. Good evening. How are you?
Fine, sir. Can I have the slides, Geetika?
Mahima, can we share?
Yes,
Dr.
yes. Please
Yeah,
share.
just give. Yes, sir. Yeah, ma'am, we'll do it from our end. Mahima, can we share the slide?
Yes, ma'am.
Yes. So good evening, one and all. So I will be speaking about lung cancer management and what the physicians need to know. Next slide, please. So the flow of the talk will be like epidemiology of lung cancer at the world level and at the level of India, and what are the different types of lung cancer and different survival rates. How is the management of different types of lung cancer at different stages, and what are the unmet needs at present, and what is the role of general clinical practitioners in lung cancer treatment. Thank. Next slide, please. So, so general physicians play an important role in the management of lung cancer because these are the primary point of contacts for any patient. Whenever they develop cough or any respiratory complaints, they go to the physician, and there the first diagnosis and investigations start. So there should be always a high index of suspicion whenever the cough or chest pain is persistent in a chronic smoker. because these symptoms are non-specific, just like any other lower respiratory tract infections or any other atypical infections, they'll be presenting. And they should be referred in the correct time to the oncologist or the pulmonologist for further evaluation. And to know, it's because chest X-ray is not enough for these patients, we should go for the further CT scan or high resolution chest CTs and further molecular tests. And these patients should be also be taken care during complications. When the treatment is started, the patient develops a lot of side effects with the chemotherapies or with the targeted therapies, and they should be aware of the complications whenever the patient is on these drugs. And after the completion of the treatment, those patients who are on follow-up and recurrences develop, there should be a high suspicion that these patients can recur, and the symptoms should be evaluated in those lines. Next slide, please. Next slide. So coming to the incidence worldwide, lung cancer along with breast cancer stands the topmost in the incidence of cancers with 11.6% of cases worldwide, and it also tops in the number of cancer deaths with 20% of cancer deaths occurring due to lung cancer. This is according to Globocan 2018 data. Next slide. So the same. And coming to India, the statistics are that it is the fourth most common cancer in incidence and the third most common cancer in cancer-related deaths occur due to lung cancer, whereas in males it is the second most common cancer occurring in India. And the average age is a decade lower as compared to the Western population, where in the Western there is around 60 to 70 years, whereas in India, on an average, around 40 to 50 years of age, people develop this lung cancer. Next slide. So we have looked into the epidemiology, and now moving on to the types of lung cancer. So next slide. So broadly, the lung cancer is classified on macroscopic level at small cell and non-small cell lung cancer. So majority of them being non-small cell lung cancer, around 85%. And again, in the non-small cell, we have squamous, adeno, the larger categories, and around less than 5% cases are attributed to large cell carcinoma or other miscellaneous types. Next slide. So small cell lung cancer account for 15% and mostly occur in smokers, and they are more prevalent in women. Next slide. And they have the tendency to metastasize very fast, and they're very aggressive cancers. Although they are very chemosensitive, at the same time they can recur, and the disease can recur and come back very fast also. So this is the cancer which has got a very poor prognosis despite being very responsive to chemotherapy. Next slide, please. Whereas on the other hand, non-small cell lung cancer is not a single subset. Histologically, it is squamous and adeno. Again, in adenocarcinoma, we have numerable targetable mutations, out of which 8 of them we have FDA-approved therapies for them, like EGFR, ALK, ROS, MET, RET, then HER2, BRAF mutations, and HER. Yes. Then, whereas in the squamous cell cancer, even though the molecular subtyping reveals some mutations and amplifications, but there is no FDA-approved targeted therapy. There is no predictive value for these mutations, like FGFR and EGFR and PIK3C mutations. Next slide, please. So more than 50% of these non-small cell lung cancer adenocarcinomas have driver mutations, most of them being EGFR, ALK, ROS, and with KRAS being 25%, and EGFR accounting for around 17%, and ALK rearrangements occur in around 2 to 8% of cases. These are the drivers because the tumor is dependent on these mutations for its growth. Next slide, please. So why are we talking about this lung cancer today? Because majority of patients are diagnosed in a later stages, that is in stage 3 and stage 4. To keep it in statistics, the resectable patients, that is patients who present in early stages, are just 25% and who are eligible for surgery, whereas around 2/3 of patients are unresectable and diagnosed at a later stage, and they have got a very poor prognosis. As we can see, stage 3, stage 4 patients, around 80% of patients are diagnosed in advanced stages. Next slide, please. So accordingly, according to the stage, the survival also comes down in decreasing trend, with stage 1 cancers accounting for 70 to 90% 5-year overall survival, stage 2 50%, and stage 3 around 30 to 40%, whereas in stage 4 it's just 10 to 13%. These are statistics in 2016. Next slide. So the management of non-small cell lung cancer in specifically requires a multidisciplinary approach, because the first point of contact is the primary care physician, and who is will be referred to a pulmonologist or a medical oncologist, which both of them coordinate with the radiologist and the pathologist, and then a cardiothoracic surgeon. It plays an important role when it is a resectable surgery. Next slide. So when we come to the how do we manage early localized NSCLC stage 1, 2, 3A potentially resectable disease, and what is resectability? If it is stage 1 and 2, the disease is limited to one lung and not involving the mediastinum or more distant sites, whereas stage 3 is mediastinal lymph node involvement detected. This is a broad category. Even in stage 3, there are a lot of subsets. Next slide. So the key role of multi-tumor disciplinary team relies whenever the patient is diagnosed with a lung cancer, whether it is resectable. If it is resectable, whether everything can be removed depending upon the patient's condition and the tumor and multiple factors, whether neoadjuvant chemotherapy should be given or upfront resection can be done. These decisions will be taken by the multidisciplinary team and then decide the further course of action. Next slide, please. So even though the early stage lung cancers occur in 1/3 of patients, still the prognosis remains poor despite giving the adjuvant cisplatin-based chemotherapy in stage 2, 3A and selected stage 1B patients. The overall survival is hazard ratio is 0.89. That means there is only a reduction of around 11% of deaths, whereas the in disease-free interval, the risk of reduction of progression is just 16%. So the 5-year OS benefit as per the LACE meta-analysis with adjuvant chemotherapy is only just around 4 to 5%. So when we see the figures down in the right bottom, in the localized early stages, stage 1B, the 5-year recurrence rates of 45%. As we go later to stage 2, the recurrence rate is 60, and in stage 3, it is around 75%. So there is an unmet need for even early stage cancers for overall survival and to improve the progression-free survival. Next slide. So in that area, the targetable drug adjuvant osimertinib played an important role in the EGFR mutant population who have been resected. In the overall population, look at the hazard ratio. In previously, we have seen with the adjuvant cisplatin chemotherapy, it's just only 0.89 or 0.83. But here the hazard ratio is just simply 0.2, and there is a wide separation of the curves. So the benefit with the adjuvant osimertinib in EGFR mutant population is very vast. And even in stage 2, 3A patients, the hazard ratio is much lower, 0.17. Approximately 83% of patients are having the reducing the risk of deaths in 83% patients with lung cancer. Next slide. So whereas in patients who are unresectable, either they go for a definitive CTRT followed by definitive CTRT or concurrent CTRT followed by sequential CTRT. These would be the lines of management for unresectable stage 3, which will be decided by the MDT. Next slide. Despite giving that triple modality or the double modality treatment, the OS rates at 1 year are just 34%, and the 3-year OS rate is just 9% in these populations in unresectable cases. But with the advent of post-neoadjuvant, post-concurrent CTRT, the adjuvant setting like durvalumab, after completing CTRT, the survival rates have increased dramatically, with 1-year OS around 80% and 2-year OS 60%, and 3-year OS is 50%, 57%. Next slide. So coming to the Stage 1, 2, 3 we have seen, and the stage 4, that's the metastatic non-small cell lung cancer. This is not a single entity. It contains M1A, 1B, 1C. M1A is just metastasis to the contralateral lung nodule or the malignant pleura or the pericardial effusion or nodules. M1B is a single extrathoracic site, and M1C is multiple extrathoracic sites. Next slide. So this is a broad overview of what how they are managed. Coming to the when the patient is diagnosed with lung cancer, the issue comes with the tissue acquisition. Most of the patients get an FNAC or a small biopsy done, for which the tissue is not sufficient for further IHC markers categorization or the molecular testing. Because these molecular tests, again, if you do a repeat biopsy, again, it takes 1 week to 10 days time for generation of the report. So patients with adenocarcinoma have these oncogenic drivers. So adequate tissue should be taken for the molecular testing. And for a broader panel testing, next generation sequencing is required. And even we need to do a re-biopsy at progression in case of targetable mutated patients, like in EGFR and NROC. And ALK. Next slide, please. So the current management of metastatic NSCLC. So previously, before 2015, it was all chemotherapy and chemotherapy only. Later, after the advent of this genomic-driven targeted therapy, like the Geftinib, and later on the erlotinib, decomitinib. So it's now the targeted therapy. If targeted therapy is negative, and if the patient is PD-L1 positive, the checkpoint inhibitors, that is the immunotherapy. We have anti-PD-1, PD-L1, and anti-CTLA4 inhibitors. The drugs, namely being pembrolizumab, nivolumab, atezolizumab in these settings. So targeted therapy and immunotherapy are now the mainstay of the treatment in metastatic NSCLC in those with oncogenic drivers and high PD-L1 expression respectively. With this, the survival improved from 8 to 12 months previously with or without chemotherapy to around 38 months with osimertinib as per the FLORA trial. And if pembrolizumab is used in PD-L1 more than 50% population, the 5-year, the median overall survival is PFS is 30 months for these patients. Next slide, please. So what is this EGFR mutation, which is the most common mutation detected in lung cancer patients? It is basically EGFR is a receptor which has got both extracellular and intracellular components coded by different exons, out of which exon 19 deletions and L858R mutations in exon 21 are the most common mutations, accounting for 90% of the EGFR mutations. So other than these two mutations, whatever mutations we are detecting in EGFR, these are called uncommon mutations. So the mutations can be either in the form of deletions, insertions, or point mutations. In the Western population, the prevalence is around 25 to 30%, and in the Asian population, it is around 45 to 50%. Next slide, please. So what drugs do we have for EGFR mutant population? In the first line, we have Geftinib, erlotinib. Second line EGFR TK inhibitors are afatinib and decomitinib, and the third generation osimertinib. The difference lies in that the first and second are irreversible. The first generation is irreversible. The second and third generations are irreversible inhibitors of the EGFR. And the added addition of third generation osimertinib is that it has got a significant CNS penetration rate, and it also acts on T790M mutant population. Next slide, please. So even though the drug was the drug started its trial in 2009, Geftinib, it received its approval in the first line in 2015, from where the metastatic NSCLC management has dramatically increased the survival of the patients. And later, erlotinib, afatinib, and decomitinib, and in 2018, the osimertinib has changed the overall survival to 38 months for these patients. Next slide. So the NCCN guidelines say that patients who are detected to be EGFR mutant population, the osimertinib is the preferred drug of choice, even though the other drugs are of category 1 recommendation. Next slide. So in those who do not have any driver mutations, that is PD-L1 more than 50%, single agent immunotherapy like pembrolizumab or atezolizumab or even pembro plus chemo also works in this population. And PD-L1 1 to 49% cases pembrolizumab matlab IO plus chemo, pembrolizumab or atezolizumab plus chemo. In case of atezolizumab, bevacizumab is also added. Next slide, please. So over a period of almost 20 years, I can say the treatment for metastatic lung cancer has evolved to the point that it was universally fatal. The diagnosis of stage 4 NSCLC is something like a death sentence, just 6 months survival. Now it has turned to a chronic illness in patients who have got targetable mutations and those who have got PD-L1 positivity. The survival has improved dramatically, and still there are some patients who die within 2 to 3 years of diagnosis who are metastatic wild type. There are no targets, there is no PD-L1, there are PD-L1 negative population. These patients do not do well. Next slide, please. So almost 30 to 60% of patients, even though they undergo surgery, they develop metastatic disease at some point of time. So there is need for improved neoadjuvant and then adjuvant treatment options in early stages. In these cases, we have seen adjuvant osimertinib played a role with stage 1B, 2, 3A EGFR mutant population after complete tumor resection, improving the disease-free survival. Next slide, please. So what are the gaps in the lung cancer, and in which areas can we explore more to improve the treatment to the patients? First of all, by improving the lung cancer literacy and awareness, and then helping early diagnosis of lung cancer by educating the general public and the physicians, and implementing the screening programs for the high-risk population, and increasing access to the newer medicines, and evolving how we think about the patient support to reflect the increased survivorship, because a lot of patients are being having an increased survival, and how to support them. So these are the areas which need to be addressed. Next slide. So still there is a hope for a future with less lung cancer if we improve in these areas. Thank you.
Thank you, Dr. Sajna. Thank you for that wonderful talk. I think we have come a long way in the diagnosis and the treatment of lung cancer. And I remember my MD days, and I think you will agree that we would not know even a single sentence about lung cancer or treatment of cancer as such. And physicians, they have a very, very important role to play when it is coming to the cancer of the lung, or for that matter, anything, because the patients, they will come into contact with the physicians for the treatment, after the treatment is completed, follow-ups, complications, etc. So I think there is a long way to go, and physicians, they are very, very important, and they should always keep a differential diagnosis of cancer as one of the differential diagnoses. So I think most of the physicians don't want to say to the patients, and patients also don't want to listen that they have cancer. And I think this makes the thing worse only, and they come in the later stages. So you delivered a very, very relevant talk regarding this. Thank you so much for your talk. Next, I would like to invite Dr. Praveen Jain. Dr. Praveen Jain is a senior consultant at Akash Institute. He will be speaking on new PARP inhibitors changing the treatment landscape in the management of ovarian cancer and beyond. I welcome you, Dr. Praveen.
So thank you, Manish. Thank you for the invitation. And 1 second, let me share my screen. So I hope my screen is visible.
Yes, so it is visible, and it is moving also.
1 second, please. Thank you. So first of all, I would like to thanks Manish, and thanks the organizers for giving me this opportunity to speak on this particular topic. So I'm going to speak about Rucaparib So, and it is definitely changing treatment landscape in the management of ovarian cancer and other cancers also. So first I'll speak on rucaparib in the management of ovarian cancer. So we already know, and we all know that ovarian cancer, there is definitely an unmet medical need, and it has got a worse prognosis. And most of these cancers, 80 to 90% of stage 3 cancers and almost 100% of stage 4 cancers, they relapse at some time point. And most of these patients, they are categorized into platinum sensitive and platinum refractory or resistant patients. And once the patient become platinum resistant, the average life survival is close to 6 months only. So it is definitely an unmet need, and we do have a lot of scope for improvement. So recently, over a period of last 5 to 6 years, so there had been surge of molecules in ovarian cancer, and mainly the treatment paradigm has changed after the availability of PARP inhibitors. So initially, olaparib got approved in third line, post 3 lines, then as a second line maintenance setting, and now first line maintenance setting. Then niraparib came, and apart from that, rucaparib also came in the second line maintenance setting. And after that, recently, Athena trial, so it established the role of rucaparib in the first line maintenance. And I'll discuss about the role of rucaparib in this. And this Athena trial, so it was an international randomized double-blind phase 3 trial, and it's not only a single trial. So it contains two different trials going together. So one was the Athena mono, where rucaparib monotherapy was compared against the placebo, and the other arm was other trial was Athena combo. So in this Athena combo, rucaparib along with nivolumab was compared against rucaparib monotherapy. And both of these trials, so they worked in maintenance treatment for ovarian cancer, fallopian tube cancer, or PPCs. So the inclusion criteria for this trial was they included newly diagnosed stage 3 or 4 high-grade epithelial ovarian cancers, fallopian tube cancer, or PPCs, and the investigator assessed CR or PR without disease progression or rise in CA-125 at any time during first-line platinum doublet. So that means they had included the platinum-sensitive patients who had responded to platinum-based doublet therapy, and these patients should have completed the cytoreductive surgery either prior to chemotherapy or interval cytoreduction surgery. And these patients, as a maintenance setting, they were given rucaparib or rucaparib plus nivolumab. And the stratification factor were on the basis of HRD status, and the HRD status for these patients were done centrally, and these patients were classified into BRCA1 or 2 mutated. So the other category was BRCA wild type, along with the LOH high category. And the third was the BRCA wild type with LOH low. And the last one was the BRCA wild type with LOH indeterminate. So the other stratification factor was response to first line platinum doublet, and whether there was any residual disease at the end of platinum based doublet, or there was a residual disease. And apart from that, timing of surgery was also a stratification factor, whether the patient had primary CRS or interval debulking surgery. So regarding the genetic biomarker status, almost 50% of the patients, they were HRD negative, 25% of the patients were HRD positive, BRCA wild type, and 25% of the patients, they were having either germline or somatic BRCA mutation status positive. So these 50% of the patients which were either BRCA mutated or HRD positive BRCA wild type, so they constitute the HR homologous recombination repair deficient tumors, and these were the subset which were being studied in this thing. So this was the trial schema. So there were arm A, rucaparib plus nivolumab, arm B was rucaparib plus placebo, arm C was placebo plus nivolumab, and arm D was placebo plus placebo. And they had included newly diagnosed stage 3-4 ovarian cancers and who had completed frontline platinum doublet chemotherapy. And So they had Athena mono analysis, so which compared rucaparib with the placebo, and Athena combo, where they had studied rucaparib plus nivolumab against rucaparib. So if we see that investigator assessed PFS, we can see over here in the BRCA mutant type. So there was an advantage in favor of rucaparib. So where the median PFS was not reached at the follow-up, and the placebo was having a median PFS of 14.7 months, and the hazard ratio was 0.6, which suggests that there was 60% relative risk reduction as far as the PFS is concerned. If we see the LOH high BRCA wild type subset, again, the hazard ratio was 0.58 and the median PFS was 20.3 versus 9.2 months with a delta of 11 months. And if we see the HRD negative subset, that means the BRCA wild type and LOH low. So again, the benefit was statistically significant with the HR of 0.65 and the delta of PFS was 3 months. So the so the PFS advantage was present, be it HRD positive or HRD negative, but the magnitude of PFS advantage was definitely maximum in the BRCA mutant subset. Then it was BRCA wild type LOH high, and then it was BRCA wild type LOH low. But all three subset they had significant PFS advantage with rucaparib as compared to placebo. And if we see the BICR assessed PFS, so again, we can see over here HR of 0.48, 0.46 and 0.6, and all were statistically significant. And we can definitely tell that the PFS advantage was present even in the HRD negative subset, but the maximum amount of PFS advantage was in the BRCA mutant subset. So this was the updated analysis, and the investigator assessed PFS at 36 months if we see. So with in the BRCA mutant subset. So it was 60% with the rucaparib, and if we see the solo one also, it was 60%. So both the drugs, so they did fairly well, and almost equal advantage was there in favor of PARP inhibitor. If we see, these are the choice of therapies as a maintenance treatment. So one is rucaparib, then is olaparib, then is olaparib plus bevacizumab on the basis of PAOLA-1 trial, then niraparib on the basis of PRIMA trial. And if we compare it with the bevacizumab, so there are few points which we should look at. So the maximum, the first point is that the maximum advantage of PARP inhibitor, it is seen in the BRCA mutated subset. And the second number advantage was seen in the HRD positive subset, and the same was replicated in the solo one and the PAOLA-1 trial also. And one point which I want to make over here is that GOG 218 with the bevacizumab continuation maintenance treatment, so the median PFS was 14.1 month. And if we see in the HR proficient with olaparib plus bevacizumab, it was again close to 16.9 months. And if we see the rucaparib in the HRD negative subset, again 12.2 months. So I just want to make a comment whether we should, so we do have both the options, whether we can go ahead with the bevacizumab maintenance, we can go ahead with the olaparib plus bevacizumab maintenance, we can go ahead with the olaparib or rucaparib maintenance. So is there a difference in HR proficient patients? So I think it is something which we should look for, whether to go ahead with the PARP inhibitor as a maintenance only, or with olaparib or with bevacizumab based maintenance, or combination of two, because there is no added advantage of combining bevacizumab with PARP inhibitor. And the thing is that bevacizumab needs to be continued throughout the treatment period, and after that it has to be continued for 15 months post chemotherapy. And the cost of bevacizumab and the side effects of bevacizumab, and the patient has to come for injectable therapies. So it is a question which I'll leave up to you, whether to go ahead with injectable bevacizumab or PARP inhibitor based maintenance therapies. So coming to the MITO 25 trial, so there were two components. One was the phase 1 component and one was the phase 2 component. the phase 1 study of rucaparib in combination with bevacizumab in ovarian cancer, which tried to look at the maximum tolerated dose and pharmacokinetic profile. And what they found out was that maximum tolerated dose of rucaparib along with bevacizumab was 500 milligram twice daily. And the randomized phase 2 portion of MITRE 25, it is further investigating rucaparib plus rucaparib maintenance treatment with or without bevacizumab in patient with newly diagnosed stage 3-4 ovarian cancer. So coming back to Athena mono, so here we are able to see the rucaparib dose intensity, and we can see over here that almost more than 50% of the patient, they did not need any dose reduction, and almost 45% they needed one dose reduction at least. But the thing to look is that 500 milligram BID, so it was a dose which was continued in more than 70% of the patient at 12 months. So it is a relatively tolerable drug, so not many side effects. And but you have to look for cytopenias, you have to look for nausea, vomitings, and then you have to make dose reduction as per the trial protocol. So these are the valid first line maintenance option. So the patient who has been treated with chemotherapy, if bevacizumab was used in the treatment phase, then continuation maintenance will be BRCA. If BRCA mutant or HRD positive, then PARP inhibitor plus bevacizumab can be used on the basis of Athena mono or Paula 1. And if HR proficient, then bevacizumab should be continued and PARP inhibitor should be added on the basis of Athena trial. And if there was no bevacizumab in the treatment, so then if a patient is BRCA mutant or HRD positive, then rucaparib, olaparib, and niraparib, all three are options. And if a patient is HR proficient, then rucaparib and niraparib are the options. So one thing which we can make out over here is that rucaparib is the option in all kind of settings, whether the patient is on bevacizumab or without bevacizumab, whether HRD deficient or HR proficient. So all of them, they can be started on rucaparib. So coming to the relapse setting. So again, coming to the concept of platinum sensitivity. So platinum sensitivity, it is called a functional surrogate marker for rucaparib. And we can see over here that almost 50% of high-grade serous ovarian cancers, they have alteration in homologous recombination repair genes. And so if we classify them, so these are the HR deficient patients. So these are the HR proficient patients. So these are probable HR deficients, and these are other patients where there may be some other mechanism playing which makes them HR deficient via upregulation of miRNAs or some other mechanism. So we can see over here that these green boxes, so all of these categories, so these are platinum sensitive. So platinum sensitivity, again, it is corresponding or it is aligned with the HRD positive status. And those patients which are HR proficient, so there the platinum resistance also comes into the picture. So it is, so all in all, what I want to say is that platinum sensitivity, it is a surrogate marker for HRD, and it is a poor man HRD scoring or HRD status. So platinum sensitivity is considered as clinical substitute for HRD, and due to this fact, many clinical trials consider platinum sensitivity as one of the inclusion criteria for patients with HR deficient tumor and will respond to PARP inhibitors. Then it should be kept in mind that platinum sensitivity may also result from defective nucleotide excision repair, and there are other pathways also which can lead to platinum sensitive, but it will not be HRD positive. So the rucaparib FDA approval, regardless of BRCA status in platinum sensitive RSU, is justified with this, and it was on the basis of this Ariel 3 trial. So where rucaparib maintenance was given in the platinum sensitive recurrent ovarian cancer, and this was the trial schema where the patients were randomized into 1:1 fashion to rucaparib versus placebo after the platinum relapse. In platinum relapse setting, those patients who had partial or complete response with platinum based doublet therapy, And we can see over here that 564 patients, they were enrolled or randomized, out of which 196 were the BRCA mutant patient. And out of 368 BRCA wild type, 158 BRCA wild type LOH high patients were randomized into this. And the rest of the patients, they were BRCA wild type LOH low. And we can see over here that those three categories again came into picture. So one is the BRCA mutant, one is the HRD cohort, which includes the BRCA mutant cohort, and one is the ITT population. So we can see over here, so it was an all-comer trial, so who had responded to platinum-based doublet. So we can see over here in the BRCA mutant, the rucaparib had a median PFS of 16.6 months versus 5.4 months with a placebo. And if we see in HRD subset also, so the benefit was there. So we can see over here the HR ratio of 0.23, HR ratio of 0.32 in HRD positive. And in fact, in all comers in intention to treat population, the HR of 0.36. So that means, so be a patient HRD positive or HRD negative, BRCA mutant or BRCA non-mutant. If the patient is platinum sensitive, they are going to respond to rucaparib, and the chances of 64% relative risk reduction as far as the PFS is concerned with the rucaparib is there. So if we see the BICR assessed progression-free survival, again, reiteration of the data that HR is 0.20 with the BRCA mutant, HR is 0.34 with the HRD positive subset, and HR of 0.35 with the intention to treat population. So this again shows that the BICR assessed PFS in intention to treat population, where the PFS was 5.4 months with a placebo and 13.7 months with a rucaparib. So on the basis of this trial, rucaparib got approval as a relapse, platinum sensitive relapse maintenance setting. So where the patient had responded to platinum based doublet. So in fact, if we see the subset analysis of this particular trial, we can see over here that the germline or somatic, it doesn't make any difference. Both of these groups, they had equal amount of benefit. Those patients who had 6 to 12 months of DFI on the penultimate platinum, say they also had a benefit, and those patients who had more than 12 months of penultimate platinum progression on penultimate platinum. So that means that 6 months which we take as the platinum sensitive disease, so that is most appropriate as far as the PARP inhibitor is concerned in the primary setting. And if we see the response to last platinum, CR or PR both have the benefit. However, the benefit was more in those who had CR with the platinum based doublet. So in the recurrent setting, so rucaparib or bevacizumab, so again the same kind of thing with the bevacizumab, that it has to be started with chemotherapy, it has to be continued, and there are a lot of risk associated with bevacizumab as far as the CA ovary is concerned. These patients, they are more prone for SAIOs. These patients, they are more prone for other kind of complications. So it is worth thinking whether to go ahead with bevacizumab or rucaparib or bevacizumab plus rucaparib. So this is something which we have to look for. So to conclude, in the recurrent setting, the functional predictive biomarker is response to platinum, and HRD has not been able to provide additional predictive discrimination to identify patients who should not receive PARP inhibitor. HRD negative patient respond to PARP inhibitor. So coming to another area where rucaparib is doing its magic, so that is in metastatic CRPCs, and we can see over here that almost 12% of patients with prostate cancer, they had germline DNA repair defects, and almost 76% of these germline defects, so they fall in BRCA2 ATM check 2 and BRCA1 mutations category. So we can see over here, so there are plethora of trials which are ongoing and which are active So they are there in the CRPC setting, they are there in the non-metastatic CRPC setting. So in almost every aspect, be it hormonal, hormone sensitive or castration resistant, so the trial of PARP inhibitors are going on as a single agent or as a combination agent. So rucaparib in prostate cancer is approved by FDA in May 2020 in those patients who have deleterious BRCA mutated metastatic CRPC, so who had previously received treatment with at least one AR directed therapy and one taxane based chemotherapy. And this approval was on the basis of Triton 2 phase 2 response data, and it was on the basis of overall response rates. So this is the Triton 2, where the metastatic CRPC patient with deleterious somatic or germline HRR mutations. So they were those who had progressed on at least 1 to 2 AR directed therapy and one taxane based chemotherapy. So those were given rucaparib in a standard dose of 600 milligram twice a day in a 28-day cycle. And these patients, if we see the response rate, the radiographic response rate, where we can see that 54% of the patient they had a radiographic response, and almost 50% of the patient they had a confirmed PSA response. So in a CRPC setting, the response of 54% or 50%, those were incredible. And we can see over here that the median radiographic PFS was 9 months, and the OS data were not mature at the time of analysis. And these were the overall response rate: 58.8% PSA response, and 54.8 was the PSA response, and 50.8 was the morphologic response. On the basis of this, that rucaparib was approved in the post AR post chemo setting. So with the approval of that, so rucaparib was moved further to the CRPC treatment naive setting. And here the standard of care chemotherapy or abiraterone or enzalutamide was compared against rucaparib, and the primary endpoint was radiographic PFS, and the secondary endpoint were OS and overall response rate. And we can see over here that 55% of the patient in the standard of care arm was received docetaxel, 24% patient received enzalutamide, and 21% patient received abiraterone. We can see over here the radiographic PFS of 11.2 months with the rucaparib versus 6.4 months with the physician's choice therapy. And there was almost doubling of the PFS with the rucaparib in this particular setting. So to conclude, rucaparib significantly increased the radiographic PFS for the BRCA subgroup and intention to treat population. And it was the first clinical study to compare a PARP inhibitor with standard of care. And it was the first clinical study in metastatic CRPC to demonstrate superiority to a docetaxel containing control arm. So after this, we will move on to the other cancer where BRCA is playing some role and PARP inhibitors are playing some role. So that is pancreatic cancer. So rucaparib monotherapy for pancreatic cancer with a known deleterious BRCA mutation. So it was looked for in the pancreatic cancer where there was this BRCA mutation, and total of 19 patients with measurable locally advanced or metastatic pancreatic cancer were enrolled after failure of 1 or 2 previous chemotherapy lines. And we can see over here that 3 patients, they had partial response. So one of them was having germline BRCA2 mutation, one was having somatic BRCA2 mutation. And we can see over here that the complete response was 5.3%, partial response was 10.5%, stable disease was 15.8%. So again, a kind of responses we see in pancreatic cancer with chemotherapy is also not great. And after 2 lines of therapy, a confirmed response rate of 15.8%. With rucaparib, it was something which was modest, and it is worth looking for. So coming to rucaparib in breast cancer, there are a number of studies which are ongoing and they are close for reporting. So we might see a data of rucaparib in breast cancer in the near future. Coming to rucaparib in the treatment of metastatic urothelial cancer. So this was the Atlantis trial, which was in the pre-COVID era. It was started, and at the time of COVID pandemic, by the time of COVID pandemic, 40 patients were randomized, and after that, the recruitment for this trial was stopped due to the COVID-19 pandemic. So, but they analyzed these 40 patients, and what they saw was that that the median PFS with rucaparib was 35.3 weeks vis-a-vis 15.1 week with the placebo, and this was a maintenance kind of setting where post 4 to 6 cycles of platinum based doublet the patient were randomized into rucaparib versus placebo. And so in maintenance, the radiographic PFS was numerically more with rucaparib as compared to placebo. And in fact, if we see the if we see the events also, so only 12% only 12 events they had happened in rucaparib arm as compared to all 20 patients on placebo who progressed with that. So with this, I would like to end my talk. And if there are any questions, I'll be very happy to answer those. Thank you.
Dr. Praveen, thank you. I think it was a wonderful presentation by your side, and I think the most of the content were either in the Dr. Prashanta's slide or your slide. So you have extensively covered all the different type of cancers with which can be treated with rucaparib. So I just wanted to know how do you approach your patients of newly diagnosed ovarian cancer? Do you send your patients for germline testing of BRCA or HRD directly? And do you use olaparib plus bevacizumab or just olaparib alone or rucaparib alone? And second question, in second line setting, suppose there is a patient who has not taken any olaparib or rucaparib in the first line setting and not undergone HRD. So do you recommend doing HRD in second line or just start these patients based upon the platinum sensitivity? Because I had one of the patient who was BRCA mutant. She was platinum resistant. Within 3 months of the treatment, the disease came back. But despite being platinum resistant and being BRCA mutated, the patient responded excellently well to rucaparib. So these are my two questions to you.
So I'll answer the first question to start with. So regarding my approach to HRD testing or the genomic profiling, so because see, the first intent of ours is to get the predictive role of these tests. So I always try to convince the patient to go ahead with HRD testing, somatic HRD testing first. If the patient gets convinced that he has to, the patient has to spend 50 to 90,000 of bucks to get the HRD report, so then I usually go ahead with that. And after that, I also do the germline BRCA testing. So that is mandatory for genetic counseling also, and that is something which we should perform. So I do both the things, but
So
first I
you
do
don't
HRD
go
testing,
first
then I
with
go ahead with the BRCA.
So you don't go with first time germline BRCA testing, despite knowing that we can have 15% of the patient who will be BRCA positive, and
The only
these
thing,
patients may not need a HRD testing uh, for the treatment perspective, and it will also serve our purpose of whether it is going to be a germline mutation and the relatives needs to be scanned or not.
no, that is another way of doing it. But then every time you need to discuss with the patient regarding this, the patient should the patient should come up with the decision at the first go, that first of all you go ahead with the BRCA germline. It will take 3 to 4 weeks to come, and after that, when the patient comes with the report, then you decide regarding the HRD testing. So you have to
But
be.
HRD testing, the results are needed only after the treatment is over.
No, that's what I'm telling you, that you persistently have to ask the patient regarding the same. So once you have the HRD test report, so the thing is that the treatment per se, the goal of treatment is out. if HRD is positive or negative. After that, there will be only a minute number of patients who will be BRCA germline mutant HRD negative. So the category of BRCA mutant plus HRD negative, so it is a hypothetical situation. So I usually go ahead with the predictive role of HRD, and that is the reason why I always go ahead with the HRD. I counsel. So, but many of the patients, they are not able to spend so much of money on HRD testing. So then I have to go ahead with the germline BRCA testing also. And in fact, one more problem comes when you do the HRD testing is that some of our patients, so they receive neoadjuvant chemotherapy followed by interval debulking surgery. And after neoadjuvant chemotherapy, there will be a subset of patients who had responded beautifully to chemotherapy. And because these patients, the BRCA mutant, they will be responding to platinum-based therapy. So the tumor fraction is so low and the yield of DNA is so low that many times HRD testing is also not possible on the surgical specimen of interval debulking surgery. So that is another reason when HRD testing might not be an option for you, and you have to go ahead with the BRCA germline for the predictive role as well. So for me, HRD is something which I always do for predictive fact as a predictive factor, and BRCA germline for the genetic counseling.
So
this is
regarding
the
second line
yes, second
testing
line.
of HRD, would you
So
recommend?
second line, if you are testing for HRD, so it leads to more confusion than solving confusion. So I think the approval is on the basis of platinum sensitivity. So I always stick with the platinum sensitivity as a surrogate for HRD. I do not go ahead with the HRD scoring. So because all of the patients, they should get the benefit of PARP inhibitor in the second line, because nowadays third line and later lines, so the approvals are being withdrawn from the company sides, and this is the last area where you can give the advantage of
So
PARP.
I am talking about those patients who are not.
No, if a patient is not platinum sensitive, then I will not consider the patient for this. Dr. Manish, are you there? Am I audible?
Yes, sir.
Yes, sir.
I think Manish got disconnected. Hanji, Dr. Manish.
This is back, sir.
Dr. Manish, you are on mute.
Yes, okay.
So we were talking about the platinum resistant patient.
And
So I do not do HRD testing in platinum resistant patients, and I am not keen in using PARP inhibitors in these patients.
okay, thank you, Dr. Praveen. I think that was wonderful. Just coming to the end, and this is the last presentation of the day. I will be starting real world evidence. Hello?
So you are not audible. Hello?
Hello? Now?
Yes, sir, we can hear you.
Hello?
Yes, sir, we can hear you.
Evidence of osimertinib presented recently, and we have been talking about EGFR mutant. We have been talking about osimertinib. We have been talking about other EGFR TKI as well. So we know that EGFR TKI osimertinib, third generation, it improves PFS and now also OS, which is better than the cytotoxic chemotherapies. Osimertinib is an irreversible third generation EGFR TKI, which has demonstrated a median PFS of 18.9 months versus 10.2 in phase 3 randomized FLORA trial. And overall survival is also better as compared to the standard of care arm. It is 36 months versus being 0.80. So I think it is the best treatment available option as of now. These are the few have been conducted. So this is the FLORA double blind study design, and the key inclusion criteria were more than 18 years of age, performance status good, EGFR exon 19 deletion. These OC standard of care gefitinib or erlotinib, and the crossover was allowed for the comparator EGFR TKI arm. Primary endpoint for the of the response. Statistic in the FLORA trial, and EGFR age was 60 years of median, more of Asian patient compared to non-Asian. Smokers were less represented. CNS metastasis was also present at a comparator arm. And you can see the primary analysis, survival for the osimertinib significant. It was 18.9 months versus 10.2 months, and hazard ratio was 0.46. And you can see on the right hand side, there was not even a single subgroup which did not respective of age, sex, race, CNS metastasis at presentation or PS. So this is the final overall survival analysis. 3 years of the time, 10% more population was surviving as compared to the comparator arm, which was 44% versus 45%. And the median overall survival was 38.6 months versus 31.8 months. So the conclusion from the FLORA trial was that it had shown a statistically significant, meaningful overall survival advantage. It has shown statistically significant, meaningful progression-free survival advantage. And it is the first EGFR monotherapy to show statistically significant overall survival benefit versus another EGFR TKI. And after 3 years, 28% of the patient in the osimertinib arm and 9% of the patient in the comparator arm remain on the first-line study treatment. And this represents a favorable and consistent toxicity profile despite prolonged exposure. So we can see on this NCCN guidelines also that this is the preferred treatment. All others are also category 1, but the preferred treatment is osimertinib. The newer treatment which have been added are dapomitinib, erlotinib plus. But because osimertinib crosses the blood-brain barrier very well as compared to the other drugs, because most of our someday develop brain metastasis and poor quality of life, and then after that they die. So I will be presenting 3 real-world evidence of osimertinib, because those patients who have been treated in the clinical trial, they are treated on the very, very strict inclusion and exclusion criteria, and most of them, they have good progress, good performance status at presentation. But real-world studies does not allow just the very strict inclusion and exclusion criteria. It, in fact, allows some of the patients who are PS, poor PS, or who have very huge burden of the disease, who are having a multiple serious comorbidity as well. So flower study, OCFAC study, and mycono study. Dr. Rajat has touched upon all these studies in his slide, and this is the first line study with osimertinib flower study in the EGFR mutant population. So this is a brief introduction. We have already discussed about FLORA trial, and it has been estimated that only 2 to 4% of the patients with cancer receive treatment within RCT, and thus raising the issue of representativeness. Only 2 to 4% patients. And hence the real world data has become a more useful tool. The key feature baseline, well, the median age was 68, so the population was a bit older as compared to the flora population. The smokers, they were even less, and former smoker, they were 34.1%, and never smoker were 54.7%. So smokers represented almost close to 50% in this. Then all the patients, they were adenocarcinoma, 95.2% patient, and few of the patients, they had squamous or adenosquamous. Brain metastasis was present in 30% of the patients here in the real world setting. Stage 4A, 23.8%, and stage 4B, 71.4%. So the population here was that population which had the maximum load, maximum tumor load. So stage 4B were 71.4%. And you can see that ECOG performance status more than 12.7% patient, which we see in our clinical practice. And these were the inclusion and exclusion criteria. Those patients who had received drug in the clinical trial, they were excluded. Histologically confirmed diagnosis, EGFR mutation 18 to 21, locally advanced stage 4, and eligible to be receiving first line osimertinib. These were the study endpoints: median time to tumor progression, rate of treatment-related adverse event, and TTD is under exploration as a pragmatic real-world endpoint. Median overall survival, secondary endpoint, median PFS, overall response rate, and disease control rate. So primary assessment was effectiveness. So patients with poor PS, comorbidities, rare EGFR mutations, and in the flora in this trial, which were excluded in the flora trial, and the outcome were similar to the published data, and thus adding the consistency to the osimertinib. The time to treatment discontinuation, this is the effectiveness graph for those patients. So it was this is related to those patients who had more symptoms or those who had less symptoms. So in the middle, you can see median TTD in the patient with or without symptoms at diagnosis. Those patients who had more symptoms of diagnosis, more symptoms at presentation, they had relatively lesser effectiveness as compared to those who had no symptoms at presentation. Similarly, median time to treatment discontinuation in patient side. So if the disease burden is high, would be more is less, and hence if the disease burden is very high, more than 3 metastatic sites, the you can see that the drug compared to those patients who had less burden of the disease. So the patients with poor PS, those who were excluded, and you can see here that the PFS, those patients who had less than 3 or more than 3 metastatic site at diagnosis, the hazard ratio was 1.094. Brain metastasis at presentation, present or absent, 2.382. Similarly, after a follow-up of 12.3 months, median PFS was comparable to that which was present in the FLORA trial. Median overall survival did not reach at the time of data cutoff, and CR rates were 0%, PR rates were 73%, stable disease was 23%, and progression was 4%. This is median PFS in those patients who had symptoms at diagnosis or who did not have symptoms at diagnosis. So that was median overall survival, and this is median progression-free survival. So if those patients who have more than 3 metastatic site or less than 3 metastatic site, brain metastasis at presentation or without brain metastasis at presentation. So these are poorer prognostic factors in this clinical trial. So longer PFS was noted in the absence of brain metastasis. Similarly, longer PFS and longer overall survival was noticed in those patients who did not had symptoms at diagnosis. So this reinforces that the patients should come to us at the earlier stages as compared to the what we are seeing in the OPDs. We see almost 50 to 60% of patients coming in the later stages. TTD of 9 months or higher was significantly associated with the better overall survival. So the real-world diagnostic therapeutic pathway, essential treatment of evidence-based medicine could help the physicians in clinical decision making. So molecular analysis was performed in 61.9% samples on progression. So 44% patient they experienced progression, and the mechanism of resistance was delineated. MET amplification was noted in 4 patients. MET amplification, EGFR amplification noted in 1 patient. EGFR amplification in 1 patient, and 1 patient had HER2 new amplification. Safety and safety data and conclusion. So you can see that a bit more number of patients had venous thromboembolism. You can see that 9.5% patient had any grade and 7.9% patient had grade 3 or grade 4 venous thromboembolism. So we have to keep in mind while deciding our patients on osimertinib. It is a good drug with very, very less side effect, but thromboembolism is one such phenomena which we should keep in our mind, that 7 to 8% patient can have grade 3 or grade 4 thromboembolism. Diarrhea. Diarrhea was noted in 39.9% patients. So in clinical practice, we don't know. As you can see that grade 3 or 4 diarrhea was just experienced by 3 to 4% patients. Similarly, few patients had rash, dry skin, and paronychia. Patient, that is 87% patient, experienced the adverse events. They had grade 3 or 4 4 adverse events. Venous thromboembolism patient. In the real world asterisk study, grade 3 pulmonary embolism noted for 2% of the pre-treated patient receiving osimertinib. And no difference in the rate of venous thromboembolism was reported according to age, PS, comorbidity, or tumor load. And on the downside of the panel, you can see that the p-value was not statistically significant for all of them. That is age, PS, comorbidity, and tumor load. So venous thromboembolism, I think, is one of the thing which we should keep in our mind, which have come up with this flower study. So second study is the OCFACT study, that is osimertinib as first-line treatment for advanced EGFR mutant non-small cell lung cancer. This is the brief introduction, and the inclusion with osimertinib as an initial treatment. Patients concurrently using other anti-cancer drug were excluded. Undergoing post-operative adjuvant chemotherapy were excluded, and recent osimertinib as a second-line treatment they were excluded. These were the baseline clinical characteristics, and you can see that the patients of PS4, they were also included. So 4 patients, they had PS4, 3 patients had PS3. So 61 patients had PS2. So more of study. And you can see here that the symptomatic brain metastasis was present in 6.1% patient, and asymptomatic brain metastasis 24.9% patient. So for selecting our patients with osimertinib, we usually try to select those patients who were asymptomatic brain metastasis, but 6.1% patient here had symptomatic brain metastasis. Leptomeningeal metastasis was also included, which was not included in the FLORA trial as such. Symptomatic and asymptomatic leptomeningeal involvement was present in 18 patients. ascites, pleural effusion, they were also present here. Pericardial fluid, and few patients they had liver metastasis. 92% patients they did not have liver metastasis. 7% patients they had liver metastasis. These were the primary and secondary endpoint. The secondary endpoint was overall survival, time to treatment failure, objective response rate, and disease control rate. So median PFS was 20.5 months, which is even more than the FLORA trial. You can see here. The other parameters that were significantly associated with PFS was male gender 1.99 HR, malignant pleural effusions 1.51 HR, liver metastasis 1.55 hazard ratio, and advanced unresectable diseases, advanced unresectable cases hazard ratio 1.71. So they were inversely related and they were statistically significant. And with respect to PDL1, median PFS was not reached in TPS less than 1%, 14.7 months in TPS less than 49%, 11.1 months for those who had TPS 50%. So this is what we discussed in the last slide. Male, they had hazard ratio of 1.99, malignant pleural effusions if present, ascites if present, this is adverse factor. Similarly, excessive liver metastasis, it was also an adverse factor. And very, very advanced stages of the disease, they were also an adverse factor. So these were the patients who discontinued treatment. On what was the reason? 16% of the patients, they had some kind of adverse event. Discontinuation was present in 219. Sorry, the reason for treatment discontinuation we can see here in 219 patients. 16% of the patient they discontinued treatment because of some kind of adverse event, and rest other they had discontinued treatment because of the progression of the disease, or few of the patient they did not had to follow up or on the patient request, and 25% patient they had some kind of pneumonitis. So this is also very, very important fact to remember, that patients who are on osimertinib and they experience dyspnea suddenly, these patients should be ruled out of thromboembolism phenomena or pneumonitis, which is a side effect of this drug. So pneumonitis you can see 12.8%. So overall response rate was 76.2%. Disease control rate was 94.1%. PFS is better with osimertinib than with conventional EGFR TKI, irrespective of PDL1 expression. Median TTF was 19.1 month. Median time from start of treatment to the onset of adverse event was 56 days. So you have to remember that most of the patients, they will develop side effects with 2 months of the treatment. And with pneumonitis, you can see that all grade events occurred in 12.8% patient, and grade 3 or more pneumonitis they were there in 5% patients. So this is another real world study of the NSCLC EGFR mutant. So this study reported a demographic and clinical characteristic along with real world time to new treatment or death and real world time to treatment discontinuation. So this was a study of study design of this clinical trial. It was conducted in the 800 sites of care. The interim subset analysis was collected through June 30, 2020, and the study is ongoing and follow-up period is planned until June 2023. The inclusion criteria were more than 18 years of age, advanced disease, mutant patients on the first line osimertinib treatment, and initiated first line osimertinib treatment from April 1, 2018. So this is the timeline of this study design. You can see that the patient identification date was April 1, 2018, and then the end date was 2020 March 31, and these patients, they had the interim analysis at June 30, 2020, and these patients, they will be followed up until June 30, 2023. So these were the assessment and the statistical analysis which were done. Baseline clinical and demographic characteristics were noted. Kaplan-Meier curve were used to generate TT, NTD, and TTD. Unadjusted and adjusted Cox proportional hazard model was used to assess the association between baseline covariates and clinical outcomes. These were the sociographic socio-demographic characteristic of these patients. So here, one important thing that I would like to take to your notice is more than 75 year of age. So more than 75, even in the 35% patient, they were more than 75 year of the age. This is very, very important. And stage 4, high disease burden was there in 81% patients. ECOG PS of more than 2, more than or equal to 2, you can see here in 14.1, 14.4, and the unknown was 31.8%. These were the EGFR mutations which were present. L858R was also adequately represented, that is 33.7%, and exon 19 deletion was present in 51.1% patient. Those were the common mutations only which we are describing. Both common and uncommon mutations, they were present in 4% patient, uncommon mutation only 9.5% patients. So these were the treatment sequences of the second line once the patient completed osimertinib treatment or stopped osimertinib treatment due to any reason. 318 patient, that is 58% patient, remain on the first line osimertinib. 18% patient, that is 103 patient, they received second line, which included immunotherapy or EGFR TKI monotherapy or chemotherapy based combination. 18% patient died while on first line treatment, and 4.7% patient discontinued first line treatment. You can see here the real world time to new treatment or death. It was the median follow-up time was 9.6 months, and this median time was 17.9 months, which was almost similar to the PFS achieved in the FLORA trial. Similarly, real world, this is the on the right hand side, you can see the forest plot, and irrespective of the any age, sex, or gender or race, the osimertinib had done well in all the subgroups. And this is real world time to treatment discontinuation. You can see it was 17.2 months, and irrespective of the Charlson index, ECOG performance status, EGFR mutation type, number of metastatic sites, the drug had worked well for these patients. So these are the take-home messages. The study provides real-world insight to the use of first-line osimertinib in the patients with advanced EGFR mutant NSCLC based on first data cutoff analysis in the US subpopulation, and the interim real-world time to new treatment or death and real-world time to treatment discontinuation results support the effectiveness of osimertinib in this real-world population. Longer-term outcomes will be evaluated in the final analysis, that is June analysis in 2023. Thank you for your patient listening. The floor is open for any questions or discussions. I know it's quite late and all of us must be hungry.
Hi, Manish. So just one question.
Yes, Dr.
In the second last study, you showed a pneumonitis rate of 25%. So did they further elaborated about that? So what was the cause for pneumonitis? And was it an infective pneumonitis or a drug-induced pneumonitis? So is there any description of that?
So it was basically an interstitial lung disease type of thing. And the grade 3 or 4 pneumonitis, it was less, but grade 1 to 2 pneumonitis, it was quite more.
But a 25% risk of pneumonitis and
but it was
almost 6% risk of grade 3, 4, 5 pneumonitis. So that is huge. So you must be aware of TDXD, that it was having a pneumonitis risk of 10% and a grade 3, 4 pneumonitis risk of close to 1.5%. And so that drug is so much into picture because of the pneumonitis and osimertinib, which we have never seen a pneumonitis rate of that intensity, that frequency. So it is something which is worth noting, because there was another real world evidence where the cardiac toxicity was also too high regarding the osimertinib. It was close to 14 to 15%. So
Dr. Praveen, these lung events, all of them, they were not high grade events. So 5 to 6% patient events, they were high grade events. Rest other were 1 to 2%, 1 to 2, grade 1 to 2. They were not high grade events. But yes, once we are treating our patient with osimertinib, definitely we have to keep in our mind that thromboembolic phenomena or pneumonitis can be one of the things which can lead to the dyspnea.
thank you.
Thank you, Dr. Praveen. So if there are no questions, and I think we are running short in time also.
So thank you, sir. Thank you everyone for joining.
Thank you.
Good night, everyone. And thanks to my colleague Mahima and Yashika. Thank you, everyone.
Thank you. Thank you, ma'am.